So objective-wise, we're going to describe the pharmacology of metformin. We're going to identify some of the potential uses of metformin in the mental health field specifically, and then outline a monitoring plan for patients on metformin. So what would you need to know to use this safely in your patients? So starting off with metformin. So this medication has been around for quite a while. It actually was a derivative of a compound found in French lilacs. So that's my tidbit of trivia for today. So how does it work? So it's a biguanide. It activates an enzyme called the adenosine monophosphate activated protein kinase. So this enzyme essentially adds a phosphorus group to other compounds. Now, in some cases, it'll turn on an enzyme. It'll change the function of a protein. In other cases, when it does that, it actually turns off the enzyme or deactivates the protein. So it really depends on which particular compound it's working on. This AMP-activated protein kinase is called a cellular energy sensor. So it's quite sensitive to the amount of glucose, the amount of sugar that's in the body, and then the other compounds that float around, whether the patient's in a fasted state or in a fed state. What it will do is it seems to increase the peripheral uptake of glucose and fatty acids. So it's going to move the sugar from the blood into the periphery, so into the muscles and other tissues, so it can be used. And it helps sensitize them to the actions of insulin, which also helps them get out of the bloodstream. Some of the other things it's going to do is it's going to turn off the synthesis of glucose and lipids in the liver. So it works on a number of other enzymes. I'm going to point one out in particular. So the acetyl coenzyme A carboxylase, it's abbreviated as ACC. This particular enzyme is involved in biosynthesis of both fats and cholesterols. I bring that one out specifically because there's been quite a bit of interest in looking at metformin's actions on essentially decreasing the activity of ACC because it seems to be involved in other processes. So neural development, they're looking at it for cognition. They're also looking at it in some forms of cancer. So potentially the ACC may play a role in allowing some cancers to be more malignant or more rapidly growing, and potentially targeting this enzyme and shutting it down may hinder some of that ability. So that's mainly in animal models, but I just thought it was interesting that this compound that's been around for a long time and is a mainstay for the treatment of diabetes is really getting diversified. Some of the things to be aware of, because it slows the intestinal absorption of glucose, it may reduce the appetite in some patients, and it's really felt that each of these actions seems to contribute to the patients experiencing some weight loss, which is going to be a huge theme that we talk about today. Interestingly, because it blocks the enzymes that create glucose, those enzymes also may be involved in the processing of lactic acid. So by blocking those enzymes, it shuts off all of their functions. And that may be one of the reasons why patients who are on this are at potentially increased risk of having elevated lactic acid levels. So we'll talk about that a little bit more also. So it works on a number of different enzymes, and how can we potentially use them? Well, specific for the mental health field, it is first-line treatment for patients with type 2 diabetes. So patients with serious and persistent mental illness are at increased risk for developing type 2 diabetes. So this is a compound that they may be on. There's a little bit of evidence, and I include it on the next slide, looking at potential prevention of diabetes in at-risk patients that may describe a number of our patients with mental illness. We'll spend the bulk of the time looking at weight gain information, so the use of metformin for patients that are gaining weight with antipsychotic medications. And then I had mentioned a little bit on the cognitive functioning. This really isn't clear, the data is not consistent, but I did want to include it for completeness sake, so we'll go over that briefly also. So I wanted to start with the role in diabetes. So it's been clearly associated with improving glucose control as well as reducing the risk of complications, both large vessel complications like problems with the brain or the heart or the kidneys, as well as microvascular complications, so problems with nerves and sensation or potentially even sight. For patients that don't have diabetes, there's much more information that's coming available saying that this medication may be beneficial to try to have them prevented from actually developing the disease. So this is a meta-analysis. It's a little bit old now, from 2008, but it was one of the best ones I could find as far as completeness sake. It included 31 trials that were at least 8 weeks long, although the average time for the trials was about 1.8 years. So they did have some much more significant longer-term trials. The patients were at risk for diabetes. So they were adults, average age was 45, they were obese, so their BMI was 32, and they may have other risk factors such as a family member that had diabetes, or some of their lab values may be getting close to the diabetes thresholds. So what they did is they were randomized to either metformin or placebo, or metformin or no treatment. So those were the criteria for all of the trials that were included. What they found was that there was a significant decrease in patients that were on metformin in the new onset diabetes. And that's actually the chart that I included there at the bottom. So it's really close to the one, but it does fall on the side where it does favor metformin, despite most of the sample sizes of the trials being relatively small. Other areas that it showed benefit in, the calculated insulin resistance, so the patient's ability to utilize in response to insulin was significantly better in patients that were on metformin. Their BMI improved significantly, so they had a weighted mean difference of 5. So that would significantly shift a number of these patients potentially out of the obese category down to the overweight category. They also saw some improvements in their cholesterol panels, with some reductions in LDL and triglycerides and an improvement in their HDL values. So overall, it looked like for an at-risk group that did not have diabetes, this could potentially at least delay for a couple years the onset of diabetes, as well as improve some of those other parameters. Those patients were not specific to patients with mental illness. They were just had risk factors for diabetes, and they did not pull out any specific mental illness data. So I can't speak for the specific population, but overall, if they're at risk, it does look like this might be beneficial. One of the areas you're much more likely to see the metformin being used for is the treatment of weight gain with antipsychotic medications. So this is a meta-analysis that was done and published in 2016. There were 12 trials. The duration of the trials ranged from 12 weeks to 24 weeks. There were a total of 743 patients. Some were first episode patients, some were chronic patients. We'll talk a little bit about the differences between the two that they found, but they also did include 2 trials that were in children and adolescents. These patients did not have diabetes at baseline, and they were given either metformin or placebo, and then followed for the 12 to 24 weeks. What they found when they pulled the data was there was a significant reduction in weight. So there were more patients that lost weight, and it was an average of minus 3.27 kilograms compared to placebo. The percent body weight loss, they lost about 5% body weight loss in the metformin group. I bring this one out because the 3 kilogram weight loss on average, okay, about 6 pounds, that could be helpful for some patients, but it's not likely to move patients that are obese and overweight into a normal BMI category. A change of about 5% of body weight is really getting close to that level of clinical significance, and they usually set that at about 7% body weight loss. So it does look like these would be clinically significant findings. And then reduction in BMI, so you see that one may have only shifted patients by about 1. So from 31 to 30. So that doesn't look quite as significant as the percent of the body weight loss. And this was over a 6-month time frame for the longest trials. This is interesting because the trials included a pretty significant range from 250 milligrams of metformin up to 1,750 milligrams a day. Most of the patients, most of the trials used 1,000 milligrams total a day, but they saw improvement even on those that were on the higher and the lower end. So overall, it was significantly better than placebo across the board for all of the weight categories. And some of these patients were on antipsychotics like clozapine, olanzapine, and risperidone. So this was definitely reinforcing that there is some efficacy when we're using metformin in these patients. The other thing I wanted to mention was, I wrote this down so I would remember, there were some that were prevention trials. So a small number were prevention, and then others were patients who were on antipsychotics and had already gained weight. So even when they pooled the data from both of those, it was significant. When they split them apart, they still saw a significant difference. The biggest group that had an impact on weight were those that were the first episode patients. So it really seemed to have the biggest benefit for those patients early on versus those that had been on chronic therapy long-term and already gained potentially a significant amount of weight. So metformin works. It seems to work better than placebo. Interestingly, in February of this year, this meta-analysis came out that looked at the potential impact of both metformin combined with lifestyle interventions. So the lifestyle interventions included dietary counseling, so encouraging an appropriate diet, as well as increasing physical activity. So this meta-analysis was only 6 trials, 732 patients. The patients were a little bit younger, average age was 33, and they had been ill for on average about a year and a half with a severe mental illness. They were on antipsychotics, a varying number of antipsychotics. At least one of the trial did include patients that were on olanzapine. And what they were looking at, in some of the patients, they were normal weight. So that was in 3 trials. In 2 of the trials, they were overweight. And in one of the trials, they had obese patients. So this was metformin and lifestyle intervention. So that's what I'm going to call the combination group against placebo, the combination group against metformin alone, and the combination group against lifestyle interventions alone. So in the first set of bars on the far left-hand side of the slide, you'll see that the blue bars are the mean change in body weight. The red bars are mean change in their body mass index. That first set of 2 is the combination versus metformin alone. The combination was significantly better for both changes in body weight and change in BMI compared to drug alone. The combination moving to the middle was also significantly better than lifestyle interventions alone. More so, a more significant difference seen in the mean change in body weight. And then when we looked at the combination group versus the placebo group, those bars on the right-hand side, those had the most significant findings, which is reassuring because we know metformin and lifestyle interventions both work better than placebo, but the combination therapy group was significantly better than them as well. So overall, yes, metformin is beneficial, but it appears that it's significantly better if we encourage and implement those lifestyle interventions in addition to the drug therapy. One thing I will say is the mean change in body mass index compared to the metformin and the lifestyle intervention group, again, you're only seeing about a 1 to 1.5 point change for the body mass index. So this isn't going to take someone that's overweight or obese and move them all the way to the normal weight category. So it's one step, but they really are going to need to be mindful of that. And this is going to be a long-term commitment, not something that gets them down to normal weight quickly and keeps them there. So that was a quick drive through the weight data. So I'm guessing no surprises there. There has been a number of reports that are looking at metformin's use for cognition. So there are a number of trials that report individuals that have diabetes that are on metformin seem to have improved cognition. And if they have mental illness, maybe it's even more significant. There was one trial done, it was a longitudinal aging study that was done in Asia that included 365 patients. They were over the age of 55 and they followed them for 4 years. What they found was there was a significant decrease in cognitive impairment. So on your right-hand side are the odds ratios for the development of cognitive impairment for patients that were given metformin. And you can see that it was significantly reduced. So they were much less likely to develop cognitive impairment if they were on metformin than if they were not on metformin at all. And the longer they were on it, the more significant that change was, as you see with the odds ratio of 0.3. So this seemed to suggest that maybe there is a role for metformin in patients who have cognitive impairment from other mental illnesses. There was a meta-analysis that was done in 2015 that included patients with diabetes and mood disorders, and they were unable to find any consistent results. So there were some improvements noted. They were not all measured consistently. The longitudinal study used the mini mental status exam. Their threshold was 23. Some of the cognitive improvements may have been just changes on the clinical global impression scale, and they really weren't standardized tests, so they were considered weak data. And there were actually some reports where there was cognitive disruption, so patients who were on metformin actually were faring worse than those that were not. So the jury is still out on what its role of cognition is, but I wanted to let you know that there is some dialogue out there about that. All right. So if we do see metformin being used specifically for patients who are having trouble with weight gain or to prevent weight gain on antipsychotics, we do have to worry about adverse effects. So the gastrointestinal effects are by far the most significant for patients starting on metformin. Diarrhea, nausea, vomiting, flatulence. There can be some weakness and headache. Those tend to go away. Patients may develop really persistent and severe diarrhea in up to, it's been reported in over 50% of them complaining of diarrhea initially, but that may be one that they have a very difficult time acclimating to. Increasing fiber intake would be very helpful, especially things like psyllium. So something that's going to be a little bit more bulk forming. They could even use things like any of the soluble fibers that are out there. That could help with it, but there may be some patients that just are unable to tolerate it. On the more severe side, there are a few things to keep in mind. It can cause vitamin B12 or cobalamin deficiency. This seems to be related to metformin impairing the intrinsic factor. So the vitamin B12 actually needs intrinsic factor to be absorbed, and metformin seems to interfere with that, and that may be part of how it interferes with some of the glucose being absorbed as well. So with long-term use, it is recommended to be watching for vitamin B12 deficiency. So as we talk about our monitoring, that's one thing to keep in mind. It can cause lactic acidosis, so patients that abuse large quantities of alcohol may be at risk for this, as well as those that may have had a significant muscular injury. And those, the most common reason for that is the development of renal dysfunction. So make sure we're monitoring that to prevent that. Rarely it can cause metabolic acidosis, and there have been some case reports of hepatitis. So ensuring that the patient has normal liver function would be beneficial. Because the GI effects are the most common and tend to be the most problematic, it is recommended to start low, so with 250 or 500 milligrams once a day. Most of the trials that have demonstrated efficacy use a range between 1,000 milligrams and 2,000 milligrams total. If you're using the immediate release product, that's divided twice daily. The extended release product can be dosed once a day, but that still has quite a bit of significant gastrointestinal distress. So you may be using either product once a day or twice a day, but the once a day really doesn't get rid of the diarrhea and the nausea and vomiting. If we are going to titrate, it's helpful to do it based on tolerability. So between 2 and 6 weeks is the recommendation. So to wait a couple weeks until they're able to tolerate it and then slowly go up on the dose. The maximum dose that's allowed is 2,550 milligrams daily, 853 times daily. For diabetes, there's been little additional benefit once you get over the 2,000 milligram mark. There's not as clear of a dose association for the weight loss with antipsychotics at this time. So they're really kind of targeting more of that mid-range, but you may see some individuals that will push it up beyond that. So we will have to monitor. So monitoring fasting blood glucose. Metformin doesn't often cause hypoglycemia, but it can. So making sure that we're watching where the patient is as far as their blood glucose and keeping an eye on their hemoglobin A1C. The renal function needs to be monitored at least annually. If there is any concern related to their renal function, then it's recommended that it's checked even more frequently, every 6 months, every 3 months, every month. It can be used in patients that have some renal dysfunction. So if they have an estimated GFR between 31 and 45, we do want to reduce the dose, and we'll watch that much more frequently. If their estimated GFR is lower than 30, it is contraindicated, so not to be used because of the risk of lactic acidosis. For patients that are going to be on this long term, it's helpful to get serum B12 concentrations. One at baseline, so we know where we're starting, and then watching it to make sure that we catch that before they develop some severe consequences of that. So they could develop anemia, they could develop some neuropathies, and we'd like to prevent that if we can. And they do recommend supplementing. If it's caught early enough, oral supplementation could be enough. There are a couple drug interactions just to keep in mind. Temporary decreases in renal function. So any patient that has iodine contrast agents, so they need any type of imaging, that can be insulting to the kidneys and may cause some temporary decrease in renal function. We will want to either hold or reduce the dose of metformin at that time. There are a couple agents that can increase the levels of metformin, so cimetidine and dolutegravir. I've never used that one. So the cimetidine can increase the metformin levels by inhibiting transporters. They both actually act as inhibitors of the organic cation transporter and the multi-drug toxin extrusion transporter, or the MATE transporter. So they're both little pumps in the kidneys that would pump the metformin out. Because they block that, then the metformin levels would get higher on the dose that they were on, and this can happen relatively quickly, increasing the risk for lactic acidosis. The last one, just to keep in mind, we can get some decreased metformin levels. So Veltassa is a potassium binding agent, so it can bind to the metformin even before it gets absorbed, thus decreasing those concentrations and making it less effective. So a couple take-home points. Metformin works on the AMP activated protein kinase, which ultimately is going to decrease glucose absorption. It decreases the production of new glucose in the liver, and it helps increase the glucose uptake by the peripheral tissue. It's definitely used first line in patients with diabetes. There may be a role in prevention of diabetes in some patients that are at risk. There is evidence to support its use for weight gain in patients on antipsychotics, both with prevention and in treatment. So patients who are on antipsychotics and already gained weight, they could lose some weight with the metformin. Tolerability definitely is problematic at first. So we want to start slow, start low, and go slow, titrating up to make sure they can tolerate it. And if nothing else, we need to monitor the renal function regularly to make sure it stays safe. So those are the main points for metformin and mental health.